So like Dr. Agarwal said, we would like to make it interactive. The best way of making it interactive is for one of you to just press your mic, turn your mic on and speak. I still can't see too many of you. The camera is moving a bit, but that's okay. If I hear a voice, I know you want me to stop, and that would be a good thing. And I would really appreciate your stopping me and either asking or even commenting or just saying, I have had this experience and this is different. That is also a learning experience for all of us. So please don't make it let it be a monologue, and please try and interrupt me as we go about with this session. So let's begin by understanding what do we mean by misconduct. The important thing to understand when we talk about misconduct in science is that very often it's not black and white. There are a large number of areas which are gray. And what that means is that if you ask two different people as to what do they think about this particular episode or a particular issue, you may get two different opinions. One person may end up saying that this is truly misconduct, where somebody else may end up saying that, no, this is acceptable, there was no problem with what you did. Therefore, very often we're talking about ethics here rather than about the law. And that is typically a problem that you have with ethics, that sometimes it becomes very easy to justify to yourself what you've done, rather than to say that it is black and white, and therefore it is debatable. I'll give you more examples of this as we go along during this talk, but a very broad example that I would like you to consider is actually from the realm of publication misconduct. Something like plagiarism. Till about 8 or 10 years ago, it was not uncommon to get direct quotes in articles that were submitted to us. Direct quotes or even entire paragraphs that were copied from a previously published manuscript, which would appear in a journal. When questions were raised that this is not acceptable, this is plagiarism, the answer would come back, but why is this considered plagiarism? It is my own article. I have taken this paragraph from my own article. I'm not copying anybody else's. So how is that plagiarism? And at that point of time, this concept of self-plagiarism wasn't very valid, and therefore it would be allowed to go. That concept has disappeared for a period of 20 years, but now seems to be making a comeback. And therefore, there are cycles in what seems to be right and what does not seem to be right. There are also circumstances in what this is acceptable and where this may not be acceptable. So the bottom line of what I'm trying to say is, and again, I will exemplify this as I go along, that you may not always have the right answer. And just because you're sitting in an audience of 50 people and 26 say this is wrong, 24 may actually say this is right. And it's quite possible that you have a divided opinion on whether this is truly misconduct or not. And that's an important aspect of understanding misconduct. The reason it's become extremely important now is the greater amount of scrutiny that healthcare and research is under. So let's again step back a few, let's say, decades ago, maybe even a century ago. Research at that time typically was conducted to help people. We knew very little about medicine, we knew very little about science, and therefore research was done with primarily one objective, and that objective was to make new discoveries to help people. You were being altruistic and you wanted to help mankind with new discoveries. That's why research was done. Over the years, and particularly in the last, let's say, 2 to 3 decades, research unfortunately has taken on a lot of monetary and financial benefits. And therefore, the altruistic nature of research has dropped. Many papers that now get published primarily because they would end up bringing a new drug onto the market, a new device onto the market, and with it will bring large amounts of money to the people who are promoting them. Now, this is again, like I said, an ethical issue. If you did not have people making money, they would do no research and you would get no new discoveries. Therefore, you would not get new drugs if nobody was making money on those drugs. You would not get new devices if there was no money to be made from making those devices. So the profit motive is inherent to progress. If there was no profit and we talk about monetary profit, there would be no progress. The problem now lies in our ability to discern what is being done purely for profit with limited scientific value versus that which has scientific value. And that is why the scrutiny on misconduct has become even greater, because these drivers for research, the financial drivers for research, now overshadow purely altruistic drivers for research. Remember, the take home from this is not that money is bad. Money is not bad. If there was no money, if there was no profit, there would be no progress. Always remember that. Those of us who sit in these ivory towers of ours, which are these academic institutions, tend to look down with disdain upon people making money. But remember, if there was no money, there would have been no progress. So that it is inherent to progress. What we are required to do is to minimize the chances of misconduct in the creation of that profit. That's all that we are intending to do here. So what is the research cycle? Where does all this start and where does all this end? The good thing is it never starts and never ends. It is actually a cycle. And what I mean by that is when you conduct research, you start with a research question. There is a question you want to answer. This is a study question. To answer that question, you design a study, you conduct a study, then you evaluate it. That's one part, the research cycle. The second part is the reporting part. The reporting part is once you've done your research, you now submit it to a journal. There are multiple types of abnormalities or problems that could occur in what you report. Then once you've reported it, it goes to the editorial office, which has its own processes and its own problems of misconduct. And therefore, every part of this cycle, unfortunately, has the possibility of some degree of misconduct. The published article then feeds a new research question. You read something in a journal. You decided that this is what you would want to do for your research, and that creates a new research question. So it's a cycle. And unfortunately, every part of this cycle has the potential of having misconduct. And similar to what I said about 5 minutes ago, misconduct is again a spectrum. There are certain things which you tend to believe are, of course, wrong, but may not be that big a deal. So you conducted a study, you took a certain hypothesis, you calculated a certain sample size for that hypothesis, but when you looked at it in analysis, it turns out the sample size was wrong. Or the denominators you took or the primary endpoints you took weren't really valid, and therefore your entire calculations are wrong. Now, what that would end up meaning is that your research may not be able to answer the question that you intended to answer, but it's probably not misconduct. That's probably more an error rather than an act of commission. On the other hand, you would have conditions where your data is fabricated or your data is falsified. You never saw that many subjects in your study. You never included the subjects that had a bad outcome. You selectively included some. Now, that's where the misconduct becomes evident, and that is called a deliberate misconduct. Therefore, there is a spectrum of problems that you could have, and the assessment of what you've done would be variable. The assessment would also depend upon your seniority and also about what are the expectations from you. Remember, we live in a community of peers. Therefore, how our peers would judge a first-year researcher or a first-year resident for a particular misconduct would be entirely different from how a senior researcher would be judged. So the same error conducted by a first-year JR is likely to be judged far more benevolently than the same misconduct be conducted by a professor with 40 publications. And therefore, that's where the issue of judgment being in balance comes into play. And therefore, for the next half an hour or so, this particular talk is going to focus only on the research part of the misconduct. Dr. Piyush Sahni is going to be talking on the publication or the reporting part of the misconduct tomorrow. Again, unfortunately, there would be some overlaps between what I speak and what he speaks, but I've modified my talk to try and minimize that overlap. So you obviously would have heard about the Belmont Principles. You've had 3 days of medical ethics, and you could not have had a discussion without the Belmont Principles. So am I right in assuming you know the Belmont Principles? If everybody is quiet, it means nobody knows about it. Okay. So I'm going to assume you don't know the Belmont Principles, which is a little surprising to me. So I'm going to assume you didn't read about it. So what are the Belmont Principles in ethics of research? There are 3 basic principles we talk about when we talk about ethics of research. The first is respect for people. That means people who are either included as research subjects or people who are likely to be benefited from that research. The bigger focus, of course, is the people who are included as research subjects. And the most important aspect is that they must be given all freedoms and must be treated with respect. I will go into more details about this in the next few slides. The next most important Belmont principle is the principle which talks about beneficence. In very simple terms, it means whatever research you do should minimize harms. It should ideally do no harm, but even if there is anticipated potential harm, that harm must be minimized. And at the same time, your research must try and maximize potential benefits. The third thing is justice, which means whatever you do must be done with all potential subjects and beneficiaries in consideration, and therefore your potential harms and potential benefits must be fairly distributed. I will explain all this. Don't go away assuming that this is just some random philosophical talk. I'll give you practical explanations for what I'm trying to say here. And therefore, I'm going to talk a little bit about the application of the Belmont Principles. How do you apply these principles in preventing research misconduct? If you understand these principles, you've actually understood all there is to understand about research principles. The first principle talks about risks and benefits. Whenever you conduct a study, and again, remember, although the bulk of this seems to be targeted to prospective analytical research, where you're recruiting subjects and either doing a trial, giving X treatment to one and Y treatment to another. But actually, it also applies to retrospective studies. It also applies to data which you just gathered from your case sheets, because misconduct can occur there just as much. So what are the potential risks and benefits of the research, both to your patients and to your subjects, and to your future patients? How completely have you informed your subjects of the potential harms of what you're doing? So how extensive has been your informed consent? Do they even understand what you're trying to tell them? And then, of course, is the issue of selection of subjects. If your research has the potential to do harm, let's say you're trying a new vaccine to see whether it works. Now, it's a new vaccine, it can potentially do harm. Therefore, the people who are likely to benefit from the vaccine must be the same in whom you're potentially doing harm. So you can't be trying the vaccine in the economically poor people of Africa when you know that when the vaccine actually comes out, the African population will never get access to it. That's a very simple way of saying that you cannot select subjects for your research if they aren't potentially going to benefit from the fruits of your research. So now let's look at its application to your actual study and your research. When you design your study, the definition of your research question and the methodology are the most important aspects of research misconduct. The first question you must ask yourself is, do I really need to do this research? Are the potential benefits of any significance at all? Is the research question significant? So for example, you want to develop, let's talk about vaccines again. You want to try out a new vaccine in a population where potentially from your phase 1 trials, you've understood that there is a 20% risk of adverse effects. You now need to understand what the extent is, how important is this problem in general life anyways? How many patients ever suffer this disease? What is the actual morbidity of the disease? What is the actual mortality of the disease? And are the benefits of my vaccine sufficient to justify even trying that vaccine? And this is obviously the question that came about when we looked at COVID. When we talked about giving COVID vaccination, at that point of time, it was clear that the benefits potentially outweigh the harms, and therefore there must be a trial. But when you go back and look at it now, and you think that the potential benefits of a vaccine may not be greater than the risk that are coming from the disease itself, should we do any further trials or not? Therefore, is your research question, or is the disease that you're studying, or is the condition you're treating really worth testing in a trial where you may harm subjects? The next question you must answer is your research even scientifically valid? So if you, let's talk about, let's say, a surgical procedure. Let's say you're doing a surgical procedure for gastric outlet obstruction. There is patients with gastric outlet obstruction, you're looking at a surgical procedure, and you want to test a procedure which bypasses the obstruction, and you're looking at a long loop of bowel to bypass it because it's simple. Is that scientifically valid? You may be able to prove that anastomosing the ileum to the stomach is a quick, simple procedure which bypasses the obstruction and the patient is relieved. But you've created a long blind loop of the gut, which will now harbor bacteria and cause more problem. Therefore, is it even scientifically valid to test such a surgical procedure? Let's look at a new procedure for doing a thyroidectomy. Let's say you've decided a procedure which can go, let's say, transrectally to go into do a thyroidectomy to avoid a scar. Now, that's a little stupid as an example, but let's assume some such random example where you can think of an example where you can do something which theoretically can be done. The surgery can be done, the end result can be achieved, but is it scientifically of any value? These are the most important scientific misconduct questions you must answer before you even start your research. Once you've decided that your methodology, that your research question is valid, the next important question is to assess potential harms. Are you studying the most valid population? If you're looking at, let's say, dengue fever, and you're looking at a medicine to prevent the occurrence of dengue, which is the population which should be studied? Are you looking at people living in an urban setup where there has never been a dengue outbreak in the last 10 years? Or should you be looking at a population in a slum area where there is a regular outbreak of dengue? So which is the population that you're studying? How are you going to assess the outcomes? Are you going to expose everybody to mosquitoes to assess the outcome of dengue? Or is it a natural experiment that you're looking at? Is your sample size ever adequate to answer your question? And this is the most important pitfall in the bulk of the research that we do within academic centers. When we pick a student and give him a thesis, and we call everything a pilot study. We give everybody, let's do 20 subjects and do a pilot study. Think, is there any valid outcome that you're going to get from such a study? Will you ever get any statistical significance to the research that you're doing, such that the research that you do is a complete waste of resources? These are the potential harms that you do from your research, which must be evaluated prior to evaluation of the validity of that research. The next area where misconduct commonly comes in is in terms of consent. If you've decided that your subjects are appropriate and your controls are appropriate, the single most important pitfall then that comes in is the one of consent. What do you mean by informed consent? How completely and how appropriately have you explained to your subject the potential benefits and harms? Invariably, the commonest pitfall that we see in manuscripts that come to our journals, or what we see in ethics committee submissions, are consent. Simply because the patient has come to you in your ward and you now decide laparoscopy versus open surgery. Is the patient really in any position to give a consent? The person who is going to go and tell him, kal operation hai, open hone wala hai, tayar ho na, sab theek hai. Do you really think the patient has any proper opportunity of giving a consent for laparoscopy versus open surgery? You will get a paper signed, he will sign on whatever you've asked him to sign, but is that truly consent? That's where the misconduct most often would end up post-analysis of the study design. I haven't had any questions so far, so I'm assuming you're hearing me and either understanding me or not understanding me so much that there are no questions. So we'll move on to the next part then. And that's the other place where you will fall down in terms of getting your articles published today. This is the borderline of misconduct versus just not being careful enough, but it can be about misconduct as well. And that's about trial registry. Most manuscripts, most journals today will not accept submissions of prospective studies, prospective analytical studies without a trial registry. And why do we call this a misconduct? We call this a misconduct because the trial registry ensures that you have done the research the way you plan to do it. What does a trial registry do? Let's say you're starting a research in 2016. You are required to register your study prior to starting it, which means you registered it in 2016, and your entire methodology is now in the public domain. You now conduct your research, and by 2020, you realize some aspects of your data are incomplete, or some analysis that you plan to do couldn't be done. It's very easy to drop that data or drop that endpoint and simply publish that which you gathered. The only way a reviewer or a general public would know that this was not your primary objective was to go back and look at the trial registry, because that shows what you intended to do in 2016. This study was designed to assess progression-free survival as the endpoint. Sample sizes were calculated on progression-free survival, therefore giving me a surrogate of complications after surgery is not a valid endpoint today. Therefore, trial registries help prevent misconduct, and therefore not doing a trial registry is considered misconduct. The next question is always about data. There is again a general tendency, particularly when you create databases, prospective databases, gather everything. Ask him everything. Ask him his mother's name, his sister's name, his brother's name. I don't know what I will use in the future. Just gather everything. And then when we look at this data in the future, we will see what we wish to use. That's a very poor way of both designing a study and of utilizing the data, and borders on misconduct. Your study data analysis or should be prospectively planned. Yes, it is true that we create prospective databases which are often larger because the study question hasn't yet been generated. We do it in a number of circumstances, but they must always be tempered with the knowledge of what are the likely uses of this data. Therefore, gathering data which goes beyond what is likely to be used is generally not recommended and could be a misconduct. The other aspects of misconduct, and again, I'm speaking primarily from an area of ethics committee's reviews of your submissions, is how was this data stored? Was it ever anonymized? Could anybody unrelated to the research have had access to this data? And finally, when you do funded research, commitments to publish. If you've entered into a tripartite or a clinical trial agreement with a funding agency, did that agency give you the freedom to publish your data even if the data was not favorable? If such a clause did not exist in your clinical trial agreement or in your research agreement, it borders on something which is unlikely to get accepted. The next issues in terms of misconduct, and this again is something coming back to what I said right in the beginning, is finances. Funding support and not declaring conflicts of interest is one of the most crucial misconducts which can actually get you to be liable. Are there likely to be any costs to the patient, cost to the institution, and methods of compensating people who are participating in your trial? All of these are evaluated by ethics committees when they evaluate whether it's suitable for research or not. So now let's look at some of these questions. And this is where I hope one of you will turn on your mic and give me an answer. We are evaluating a new drug for hypertension. What should be the controls? Should the controls be metoprolol, which is an established antihypertensive agent, or should it be a placebo? What should be the sample size? If I take a sample size of only 300 subjects, the arterial pressure difference between the two groups would have to be a minimum of 10 for it to be statistically significant. This is a well-known part of study design. On the other hand, if I want a narrower difference to be picked up, say a difference of 4 to become statistically significant, I will need 3,000 subjects. So the question to all of you, what should be the placebo? What should be the control? Should it be metoprolol? Should it be placebo?
So
What
let's
would you
answer that question. So what do you think, Nitin? What would you like to have as control, metoprolol or a placebo against a new drug? So metoprolol. Anybody else has different views? When if you are in the control arm, what would you like to have? Metoprolol or placebo? So Rajeev, everybody thinks it should be metoprolol.
Right. So when you have a standard of care, and not just one, you have dozens of drugs which are standard of care. To deny standard of care would be difficult. It would be difficult to justify. On the other hand, it is not surprising even today to get trials which compare a new drug to a placebo. Would that be called misconduct, or would you be able to justify it in certain circumstances? Is there a circumstance where you could justify a placebo, even though there is a standard of care?
So can you give some example where you can justify having a placebo controlled trial? Anybody? Pardon, just put on the mic. Your mic is not on? So they're saying that if you have a terminally ill patient with cancer, so there you can justify the placebo.
I would actually take it the other way around. I would say when the disease does not cause any major harm and the standard of care has significant adverse effects, that would be a condition where you would be justified in probably using a placebo. And therefore, again, the reason was not to find the right answer here. The reason was to say that both could possibly be justified. There would be circumstances where you could say standard of care should be the control. There could be circumstances where you could say placebo should be standard of care, should be the control. The objective of trying to show this out is it needs a lot of thought when you design your study, because what one considers as acceptable, the other would consider as misconduct. Now let's look at the sample size issue. What sample size would you want? Do you want 300 subjects? Do you want 3,000 subjects?
One of you can tell. What sample size would you like to have? 300 or 3,000? People for 3,000. Who are the people for 3,000? Raise your arm or raise your hand. So we have 5 people who say 3,000. So that we assume that the rest of you think it should be 300. Pardon? Efficacy is given to you. That if you are looking for a mean blood pressure difference of 10, or are you looking at the mean blood pressure difference of 4 between the two arms of the study? Just put on your mic. The mic's not working. Just
working.
Please speak in the mic.
Prevalence is more, so I want to have more sample size.
Okay. So the prevalence of hypertension is high. You want to have a higher sample size. Anybody?
Okay.
The 300 subjects. What is your argument for 300? Let's put on a mic. Okay. So the person who is saying 300, he says that because it's a new drug, you're not knowing the side effects of the drug. So you don't want to expose more people to that new drug. So you would use 300.
Right. So again, like I said, no right answers. You could look at various circumstances and various arguments to say one is right versus another one is right. When you're looking at hypertension, you could potentially say that a mean difference of 4 really doesn't make too big a clinical difference. And therefore, I don't want a large sample size if the difference is so small. On the other hand, you could justify it by saying the new drug has negligible adverse effects compared to the existing ones. And therefore, even if the difference is small, it's better than one which has severe adverse effects. You could probably justify a larger sample size. If we were to move on to another circumstance, let's say cancer, a drug which increases survival by 3 months but is inexpensive and has no adverse effects would probably be more valuable than a drug that increases survival by 6 months but is very expensive and is very toxic. So all that these examples are trying to tell you is that these are areas which are gray, and therefore they could easily be considered as misconduct if they are not appropriately addressed when you're justifying the decision you took. Why do we harp so much? Why is this misconduct? Why is it just not a difference of opinion? The reason we harp so much about it is because all potential research can cause harm. If it turns out that your mean arterial pressure difference of 4, mean BP difference of 4 was actually clinically useless, you potentially subjected 300 subjects to harm by including them in a research. Therefore, your every step of what you do in your research study, your design, and your interpretation has the potential to cause harm and can be misconstrued as misconduct unless you have reasonable explanation for justifying why you did what you did. Therefore, placebo or no placebo, 300 versus 3000, and should you be reporting that which works only in a subset of your population versus your entire population, depends upon how you've analyzed your data and what was your primary endpoint. Now let's look at another research question. This is a randomized trial for a new drug for diabetic retinopathy. The primary endpoint was to prevent blindness. That was the primary endpoint. Does the drug prevent blindness? So when the study was conducted, it was found that everybody who had a fasting blood sugar of 200 milligrams per cent or higher dropped out of the trial and directly got a laser therapy done for their retinopathy. Among all the remaining subjects, the mean blood sugar improved from a fasting of 160 to 140. However, there was no prevention of blindness and there was some hematemesis. How would you report such a study? What would you report out of all this?
So people, some of you can tell us, what will you write? We just discussed, no? That you have to register your trials. So probably the trial will register it, probably. We have some endocrinologist who can tell us, what will you write in this results of this study?
How would you avoid misconduct in how you write this study? Okay, I'll give you the answers. I have a few more slides to go and I see where we won't have enough time for them. Remember what I said about registering a trial, what Madam also mentioned just now. Why did you want to register your trial? Your primary endpoint was preventing blindness. Therefore, your primary answer has to be it does not prevent blindness. That has to be your primary endpoint. But then there are a number of caveats in your study, and which both go in your favor and against you. What goes in your favor? The population that was most likely to benefit from your drug was the ones who were severely diabetic. They are the ones most likely to become blind, and therefore they are the ones most likely to benefit. But they opted out of your study. They dropped out. Therefore, the people who are most likely to benefit never took the drug. Therefore, you can't really say whether it helps or not. On the other hand, the fact is that your sample size dropped. You did not help the patients who were in the trial, and therefore your primary endpoint is negative. What is the bottom line of this example? The bottom line of this example is how you report your study, and which is where the misconduct would come in. The fact of the matter is that the glass is always half full. Very rarely would you get a study which is entirely one way. There would be some pros, some cons. What is important to avoid misconduct is to ensure you report it without bias. You report the facts as they are and you interpret them as they are. So let's assume you got a study in which you get 6 marks. You can also find study in the literature which got 5 marks. You could potentially quote all others which quoted 5 and say, I am the best because I got 6. But if you are fair, you would also quote some who got 7 and justify that you are poorer than the guys who got 7, but give a justification for why you got 6 when everybody else got 7. So that's where misconduct could come in terms of how you reported your study. Did you give all your data? Did you report it as per your primary endpoint or not? Now let's take you on to another research question. You read an article in the New England Journal of Medicine This is a randomized controlled trial that has been done by a top-level researcher at a top-level institution. It's of undoubted quality, undoubted ethics. The research has been beautifully done. And then it says that a new drug X that they've tested is better than an existing drug Y. What is our response reaction likely to be for the bulk of us? Most of us are likely to assume that this new drug potentially works. We are likely to be enthused by the new drug, and some of us may even start writing the new drug because it's actually been done by a top-level researcher, and the research is truly beautifully done. There is no cheating. I mean, it's truly well done. Many of us are likely to be favorably inclined towards the new drug. Now, what happens a few weeks down the line? Another study appears in the New England Journal of Medicine. Another beautifully done study, similar to the first one, but this study finds drug X is not better than drug Y. So you've now got two studies, and this happens in science. You've got one good research which says it works, another good research which says it doesn't work. What do we now do? Most of us are going to be in a bit of a dilemma. Some of us would want to use it. Some of us would say, well, maybe it's good, maybe it's not good. Maybe I'll wait for a few more studies. Maybe I'll wait for the guidelines to say whether I should use it or not. But to a large extent, for the bulk of us, the decision would now be ambivalent. Am I right or am I wrong? Okay, I'm assuming I'm right. That's how it works. I'm assuming I'm right. We are now a little ambivalent. So what happens next? 2 weeks down the line, there is a newspaper article. The newspaper article says that the lead author of the first study owns the company that makes the drug. Now what happens to our interpretation? Now what do we do? Our natural reaction now is that the first study was a fraud. The author made money on that study, on that research. The second study says it doesn't work, yet the first study said it worked, therefore he must be cheating and the data must be wrong. Am I right in this interpretation or am I wrong in this interpretation? Is this how most of us would naturally react? Again, I'm going to assume the answer is yes. I can't hear you guys. I'm going to assume the answer is yes. This is the natural reaction. Our reaction is right. This is how we naturally react. Why did we react like this? We reacted like this because we now believe that the guy who wrote the first paper has a conflict of interest. He's making money on it. That is why he reported it as being better. Whereas it is probably not better because that's what the second study says. But now let's go back to what I told you when I first started this example. The first thing I told you was this study was beautifully done. There was nothing wrong with the research. The research is truly ethically and beautifully done. Yet we chose to disregard it the minute we realized somebody is making money on it. Our natural reaction was that even though the research is brilliant, there is a conflict of interest and therefore the research is false. This natural reaction that we have to a conflict of interest is what often prompts researchers to leave their name out of the publication and they become ghost authors. They also know that having their name on the paper will take away the credit from the paper and therefore they would not get the value that they have. This is called conflict of interest. And this is, again, a very important aspect of research misconduct and something which everybody in academic institutions needs to be aware of. Almost all of our research is funded extramurally. The good part of our research is that the bulk of our funding comes from government institutions, and therefore the concept of a conflict of interest is negligible. On the other hand, the fact is that a large amount of research even today gets done with the pharma industry support, which is perfectly fine. Remember my beginning talk half an hour ago, there's nothing wrong with getting support. But the fact is that this declaration of this conflict of interest, the declaration of They supported me for travel to a conference. They supported me for a lunch. They supported me for funding. All of this must be declared when you declare your research. Why is this important? Apart from the example I gave you, there is actually enough data to support this. When the calcium channel blockers first came on the market in the late 90s, there were a number of publications which supported calcium channel blockers, and there were a number of papers which said calcium channel blockers don't work. So this study, which was reported in the New England Journal in 98, looked at all these papers and found that whenever one of the authors had pharma relations, 100% of them reported the study to be useful. Or let me flip that. It is the other way around. Among the studies which said that the calcium channel blockers are useful, every study had at least one financial relationship with the pharma industry. On the other hand, among the studies which said the drug is not useful, less than half had a relationship with the pharma industry, which clearly showed the influence that funding had on how we reported our research. Therefore, declaration of conflicts of interest is considered a very important scientific research misconduct. And if you conduct research without separating your financial aspects of it and without declaring those financial aspects when you're talking about your research, this is likely to be considered as scientific misconduct. I have a few case studies on misconduct, but I know that I have only about 5 minutes left of my talk, and therefore I'm going to stop here.